or paediatric day unit. When a patient is referred to CHAT, they aim to contact the family within 2 hours, and then they offer phone support, a plan of care and home visits if required. CHAT will provide a nursing assessment and will support families with fever management, fluid intake, so they'll provide fluid challenges at home. They'll provide respiratory assessments. CHAT have a very close relationship with the medical team on the paediatric day unit, and they will refer up to be seen on the day unit if required. On average, children are on the caseload for 2 to 10 days and only discharged when the families are comfortable. To look at a bit of data from the last 3 years, the bars show home visits and the lines show telephone calls. You can see that during COVID, CHAT were very quiet, and this gave them time to develop their service further and develop new pathways. We are currently seeing very high numbers, as I'm sure you would expect. And for September, we have already had 162 referrals, which is the highest yet, and the team have already made 1,000 telephone calls this month. The CHAT team will submit data to commissioners to highlight hospital avoidance rates each month, which is generally over 90%. However, in the last few months, this has dropped and more children have needed to be admitted to hospital. But I think this reflects current activity levels, acuity, and also that a lot of these children will be going home on the bronchiolitis pathway, which by nature of the disease, they'll get worse before they get better. I've put up a few quotes from families when we ask for feedback, and certainly they find it very reassuring to go home with this follow-up service. A lot more confident to go home from the wards early, and a lot more confident not to be admitted to hospital, and everyone prefers to be at home rather than in hospital. You always know a service is doing well when funding is approved to expand it, and that's what's happened for the CHAT team. So we are expanding from 3.5 nurses to 14.5 nurses. We're currently recruiting and hoping to offer this service imminently. So if anyone else is looking to try to support managing their children in the home environment instead of in hospital and would like to see any of our pathways or would like to have access to any of our data, then please do contact me. Thank you.
A big thank you to Tara and the team there for a really amazing presentation. 1,000 phone calls so far this month. That is incredible. And actually it feeds into an awful lot of work that the college has been doing about bringing care close to home. So lots of food for thought for all of us around the region. We're now moving over, just jumping over to Portsmouth, and we're going to have a medley of various exciting projects that Portsmouth have been doing recently.
Welcome to Portsmouth. We want to share with you what's new here, and to start with we have our new balcony area for the children to play with. Next you're going to hear some of the new things that we're proud of to share with you.
Hi, my name's Debbie. I work here at Portsmouth Hospitals as a safeguarding children practitioner. My role was developed at the end of last year to support the children's wards with their safeguarding practice. I also facilitate our peer reviews, which delivers peer supervision to all our consultants and medical staff.
In order to manage outpatient waiting times, we've introduced a system of open appointments, which means that parents can book an appointment themselves if needed within an allocated time frame. This has reduced the DNA rates, but also maintained parent confidence in being able to access help when needed. We've also changed from using e-referral to advice and guidance for all GP referrals. This allows us to direct patients into the correct clinics, but also to provide timely management advice such that parents and children don't need to be seen in clinic, but can still get the care that they need. By doing so, we've reduced our waiting list by 2 weeks, and children are mostly seen within 6 weeks of referral.
Hello, my name's Kathy. I'm a music therapist working here at Queen Alexandra Hospital in Portsmouth in partnership with George's Rockstars. Through music therapy, we give children the opportunity to to have some fun, to express themselves, to feel listened to, communicate whilst they're in hospital, and mostly have a really good time.
Hi, my name's Sammy. I'm the sister in charge of children's outpatients here at QA. A little over 5 years ago, we started doing a prolonged jaundice clinic here at QA in the outpatient department, which was run by the junior doctors. A nurse-led clinic. It's run by myself and some nursery nurses. It runs very well. We do 2 clinics a week, which we can see up to 5 babies per clinic, but we're looking to increase that to 3 clinics a week. Because of the referrals coming in, there's quite a lot at the moment referred by the midwives and the community teams. The benefits of having a nurse-led clinic includes improved patient experience, easing pressure on the consultants and the junior doctors, and ensuring continuation of care. So we assess the babies as they come in. We follow a strict protocol that we've made up, and that includes taking a brief history of their things like their feeding and their behaviour, any past history of jaundice, and we also take some bloods. We then can chase those bloods up, and depending on the results, either send a letter of discharge home or go to the consultants to get some support as to further guidance about what to do. At any stage, if we have concerns, we can go to our consultants to get support throughout the whole experience. But overall, it runs very smoothly, and we hope to continue this service and maybe more nurse-led clinics in the future in other areas. Thank you.
Thank you for listening to our video. I hope you enjoyed it.
That's brilliant. It's good that Emma didn't get blown away there at the end, and it would be amazing if anyone wasn't smiling at that music therapy session. I think that should be a key for anyone in hospital. How brilliant. We're now just going along the coast to Chichester, and they've been doing some work particularly focusing on induction for international medical graduates.
Hello, my name is Jo Milton. I'm a Paediatric Education and Leadership Fellow working at St Richard's Hospital within the University Hospitals Sussex NHS Trust. We'd like to shine a spotlight on our new Induction for International Medical Graduates project. This is based on recent GMC workforce report, which showed that over a third of UK doctors are considered international medical graduates or graduates from the European Economic Area. This is also reflected in the paediatric doctors in training population, with 14.7% being IMGs and 5.6% from the EEA. Feedback from current international medical graduates regarding the existing induction programme highlighted the variability in information and support received when starting in the Trust. Health Education England recognises that the transition to living and working in the UK can be difficult, and therefore a trust-wide plan was suggested to ensure we are fully committed to supporting IMG doctors during induction to the NHS and to aid in their continued well-being. The team had an initial 2-step approach, firstly providing information prior to starting in the form of a departmental booklet and a booklet with general information on both living and working in the UK. Secondly, offering the opportunity to attend a pilot communication and ethics workshop programme to improve familiarity with UK healthcare structures, ethical principles and GMC guidance. The focus on communication skills and ethical scenarios was based on a survey of the current IMGs at St Richard's and Worthing hospitals, with results suggesting that the majority would have found additional teaching on these subjects useful during the induction process. A pilot project was created to trial the introduction of these workshops. The approach was utilising a virtual format over Microsoft Teams due to COVID restrictions, with 4 1.5-hour sessions. The initial 30 minutes was focused on the theoretical element, including GMC guidance, legal aspects and relevant communication strategies, followed by 2 30-minute virtual role plays, including time for debrief and participants to ask questions. The 4 subjects covered included breaking bad news, capacity and consent, DNA CPR and advanced care planning, and dealing with angry patients or relatives and complaints. Feedback from these sessions was overall very positive, commenting on the relevance to daily practice as well as the interactivity of the role plays. The plan going forward is to offer regular workshops throughout the year with continued feedback to ensure that the workshops are fit for purpose, and trust-wide to employ an overseas doctor lead and to consider initiation of a IMG peer support group. Thank you for listening.
Super, another great initiative, and actually many of you will have heard of the Soft Landings team who are looking at this particular issue on a national scale, so do check them out on Twitter and online, because they have a whole host of mentorship programs and workshops dedicated to supporting international medical graduates, particularly within paediatrics. We're now heading over to Southampton, and one very clever Dr. Ahmed has put together quite an extraordinary video to entice people into working in PICU. Do spot the cameos of people that clearly do not work in ICU that Ahmed's dragged into being part of. We look forward to watching this video. Wowzers, Ahmed, you are incredible. Well done. I don't know about you, but we've all been dancing around in here. So if anyone wants to film a little video of them dancing around to Piku's song there, then please do share it with us on our Twitter feed. We'd love to see it. We're now scooching over to Poole, and many of you will know that Poole is undergoing quite a lot of change, and actually we've become University Hospitals Dorset recently, amalgamating with Chichester and Bournemouth, and hopefully in the next few years we will be relocating our paediatric department to a purpose-built brand new department in Bournemouth. So Dr. Wadhams will be sharing our plan for this with us just now.
Hi, I'm Dr. Steve Wadhams. I'm a consultant paediatrician at University Hospitals Dorset. This brief animation shows how we plan to develop the new Child Health Department to be based at the Royal Bournemouth Hospital site as part of a major £250 million transformation of our services at University Hospitals Dorset. This has been planned over the last 4 years with regular input from clinicians from both Poole and Bournemouth sites, contributing to designing a state-of-the-art, bespoke, modern children's department conforming to national standards, fit for the future needs of our local population in East Dorset and beyond. We arrive at the main entrance of a new facility at the Royal Bournemouth Hospital, which will contain a maternity and children's unit as well as emergency and critical care. We then walk through the reception and waiting areas, passing retail and a range of accessible facilities. We now go through the double doors and into the lift lobby, taking a lift to the 4th floor to enter the Child Health Unit. We start our journey in the Child Health Unit with the view of the 4th floor lobby to the inpatient ward, going past the main reception and office area. As we move through the department, you can see the side room with ensuite facilities which will be used for delivering private and dignified care with excellent infection control. Walking through the circulation areas, we now enter the wet room, which will be used where extra assistance is required for personal care. carrying on the journey, we pass the staff bases on either side, passing the isolation rooms to the left, we now enter a further ensuite room which will be part of the adolescent area of the children's unit. Next, we come into our spacious 4-bedded bay with toilet and ensuite facilities. We then move on to the MDT room, which is used for bringing groups of professionals from the multidisciplinary team together alongside parents, carers and children to plan and agree care in a number of different situations. This is a hospital school room, which is an open plan, vibrant learning environment which helps maintain access to education during hospital stays. Here we see the playroom, with play being an essential part of preschool age children's education. The play team work here delivering specific play programmes to assist families with medical and nursing interventions. We finish with a secure outdoor terrace area which forms an extension of the play facilities. For more information on this development and the future plans for University Hospitals Dorset, visit the Investing in Our Hospitals section of our website.
A big thank you to Steve there for talking us through what is hopefully a once-in-a-generation opportunity to have a brand new unit. Very exciting. Last and by no means least, we are scooting up the A338, I think it is, up to Salisbury directly from Bournemouth, where the guru of NIPE himself, Chris Anderson, is going to be talking to us about their new NIPE checklist.
You can use the newborn infant physical examination can be a cause of constant constellation. Junior doctors sometimes forgetting all they need to do. You see, every baby's more or less the same routine examination, slightly different name. Did you definitely particularly remember every part? Did you? Did you? After a clinical event we fear, we had to come up with a slightly safer idea, how to reassure every mum and dad. This is the story of the idea we had. Hooray! NIPE clipboards.
The NIPE examination to be done by 72 hours of age. Documentation is not always clear or written on a page. We've had a few incidents, hips are the worst, so we came up with an idea to reduce the SIAF curse. The small little baby, so precious and new, in comes the doctor and midwife and says, "I'm here to do the NIPE for you." Mum looks anxious, a little bit scared, but it's all okay as you've come prepared. The new NIPE clipboard with resources galore. How do we manage without them before? For mum an information sheet and questionnaire, QR codes and the checklist, it's really all there. Mum reads through the info and completes all the forms. The doctor or midwife now feels better informed. Together they go through the questionnaire to make sure there are no unanswered questions in there. The NIPE examination is then performed and parents will hopefully feel fully informed. Referrals are made without any delay and questionnaires are then filed away. And when those incidents happen again, we can use this documentation to mitigate against them.
So if you want to share our documents, you'll be sharing the same dream. Email the screening team.
Oh dear, that is truly fantastic. Thank you so much, Chris, and the whole screening team there in Salisbury. I think it's a challenge for us all for next year to have, I don't know how many instruments there were in that presentation, but perhaps we can all up our game and include musical instruments next year. I don't think we probably don't quite have time for specific questions just now, but the chat is still running, so by all means put questions in there, and then representatives from each trust may be able to answer them. Otherwise, we will make sure that people can get in contact with each trust to learn and understand more about their initiatives and how we might replicate great practice across the region.